You have a seizure disorder, you know someone with a seizure disorder, or you're generally curious about seizures, why they happen, and how they are treated, especially in the hospital. In this episode of the JAFERD Cast, we're talking all things seizure disorders, status epilepticus, and even conditions that can mimic seizures, but are actually not. Let's fucking go. Welcome, everyone, to this episode of the JAFERD Cast. I am your host, Dr. Mark Papadakis. Nobody particularly important, just another fucking ER doctor. This week, we'll be talking with Dr. Danielle Landau, neurologist, mainly about seizures and seizure disorders. If you enjoy the content, be sure to follow us on all your favorite podcast apps, as well as on YouTube. Find us on social media as well. I regularly post clips of episodes and in general spam the ever-living daylights out of my followers with medical nonsense. So without further ado, let's bring them in. All right, I'm here, Dr. Danielle Landau. Dan, hey, how you doing?
I'm good, Mark. How are you? Thanks for having me.
Very good. I'm glad you could be on here. So, Dr. Dan Landau went to medical school at NYU and then did residency at first at Montefiore in the Bronx, and that was for just general neurology, correct?
Yes. Well, it was the first year was an internal medicine prelim year, and then 3 years of neurology.
Okay, and then you did fellowship in vascular neurology at Montefiore as well, which is more commonly associated with like strokes and diagnosis workups, things like that, right?
That's correct.
Okay. What prompted you to go into neurology? So first of all, like, you have to understand, everybody in medicine thinks neurologists are like the smartest person in the room of all times. So what?
Yeah, if you're not in the medical field, I do get that a lot. But honestly, it's just the ones who are more nerdy who end up going into neurology.
All right.
I don't think it has any basis of knowledge base or skill. It's just whatever your preference is. But the reason I went into it, it was really just a matter of what I thought was most interesting. And I was doing my rotations on my third year of medical school, and I was just basically narrowing things down that I didn't like. And eventually I either got left with internal medicine or neurology. And it just, the diagnoses I was seeing, the physical exam, so I felt a little more hands-on with a lot of the things that we did at the bedside. So that it was a combination of things, but ultimately just neurology just sparked the most interest in me.
That makes sense. I had a very similar situation where, you go through medical school, your third year, and you kind of rule everything out, basically. Nothing, you either A, go in there thinking, okay, something is going to speak to me, or you basically go through something, you're like, oh, I hate this. Next rotation, oh, I hate that. And then you're left with basically whatever is left over. A lot of my classmates have had that very, very similar experience.
Yeah, I only knew a handful who knew immediately on day one of medical school, I will be an ophthalmologist, or I will be a urologist. Like, there were very few who were like that. Most I felt were in my camp, who just knew they liked medicine in general, but didn't really know the pathway.
When you get into medical school in your third year, you're thinking about your career, but it's very unfair for medical students to figure out, okay, this is what the rest of my life is going to be like after a month or two in a specific specialty. Medicine is so specialized nowadays that, yeah, you got to figure out, well, if I'm going to do internal medicine, great, more options are open to you. But if you want to do surgery or if you want to do psychiatry, you got to know that day one. That's something I didn't even realize going to medical school, how much pressure is on you to figure something out so early.
And I think nowadays, I mean, it's been, I don't know how many years since I was in medical school, but I think they're trying to get students into the clinical setting earlier and earlier to try to give a little taste of what it might be like when you're out of medical school, rather than only having that 1 year window. Third year medical school, they throw you into the wards, and then you got to apply within 1 year, as if you already know what you want to do.
Yeah, and you're also taking your board exam. So you're gearing up for, you already took one, step one board exam. Now you got to take a second set of board exams at the end of your third year while managing residency applications, while trying to figure out your rotations. It's a lot. People don't realize it, especially those who are peripheral to the medical field. They don't know what kind of education and training goes into it. So the main topic for this session is going to be mostly seizures. And actually, this comes from a viewer submitted request. She was a former nurse of mine, and she wanted to talk about epilepsy and seizure disorders, and in a way discuss some of the stigma behind that. I think one of the common questions that I get if I have a first-time seizure patient in the ER is, why? Why am I having a seizure now? All of a sudden, do I have a seizure disorder? What is going on right now?
Yeah, and that is basically the main question that needs to be answered, because a seizure is really just a symptom. A seizure can happen to anyone, and some people are predisposed to seizures. People who are predisposed to seizures, who have recurrent ones more than once, those are people who are diagnosed with what's called epilepsy. But if you had a first-time seizure and the cause is not known, that's where the neurologist comes in to try to figure out, is this just a one-off event that may never happen again, or is there something in the brain that's causing this that could potentially happen in the future if not taken care of? So yeah, there's a wide range of why people have seizures. Every patient is different, and getting to the root of why it happened can help prevent this from happening in the future.
So I'm a big video gamer. I've been
Yeah.
playing video games since I was 5 years old, but I remember at an early age seeing in the instruction manual warning, do not play if you have like epilepsy or seizure disorder. So I grew up thinking, okay, flashing lights triggers seizures. And I was thinking like, well, am I going to get a seizure from this? And I think, I don't know, is that something that can trigger it on everybody, only certain people?
Yeah, so the flashing lights, that is something that makes a seizure more likely to happen in someone who already gets seizures. So someone with epilepsy, you expose them to what's called photic stimulation or repetitive flashing lights. That can make it more likely for that person to have a seizure. But if you're someone who's never had seizures before and then you get exposed to flashing lights, you should not have a seizure. But there are other things that can cause a normal, healthy person to have seizures that are sort of outside the brain, that in anyone, like very low sugar levels, for example, can provoke a seizure in anyone. There's certain other things that we can get into that. But basically, flashing lights should only really cause a seizure in someone who has epilepsy.
And somebody who has epilepsy, now, do you see patients who have epilepsy who have just epilepsy alone, or is it usually associated with other conditions, immune conditions or, chronic malformations, like whatever? Is it just a singular diagnosis?
Well, more often than not, well, I guess it depends really what subset of people you're looking at. I treat adults, but if you're a child who has epilepsy, children with epilepsy can have associated conditions as well. There can be some congenital malformations of the brain that can cause seizures. But once you start seeing seizures in adulthood, it doesn't have to be associated with any other conditions. It can be just, there are different forms of epilepsy, something called juvenile myoclonic epilepsy. These are things that can develop in your teenage years, and you don't have to have any other conditions. You can be a normal, healthy person without anything. You don't need to have an autoimmune condition. You don't have to have some type of in utero developmental problem. So it is a wide gamut. But yeah, there are some people with very difficult to manage epilepsy who typically do have some type of brain malformation, and those are diagnosed at a very early age.
Your primary practice is mostly hospital-based. You don't really have office settings, correct? So you see them mostly in the acute settings as opposed to like chronic management, correct?
Yes, that's correct.
Okay. So basically, you're not an epileptologist, you're just a neurologist. You're just a freaking neurologist is what is what I'm saying here.
Yeah. So I don't read the EEGs. I don't see people in the office for their checkups, their follow-ups, their medication adjustments. But if someone's comes to the hospital with a seizure or multiple seizures, they'll get admitted to the hospital, and I'll manage their care when they're in the
you're getting a
hospital.
phone call from me usually too, if I'm getting somebody we've taken care of together a few status epilepticus cases where basically it's, status epilepticus is a series of seizures that last for a very long time, and we're talking 15 minutes or more.
Yeah.
And then, I'm giving them medication after medication to try and break the seizure. And then ultimately, if it doesn't break, now I'm giving them a third line of medication that effectively can really significantly depress the respiratory rate. And now I have to put them on a ventilator, ICU them. And those patients, what's interesting is they could still be seizing. We don't know it because ultimately I'm giving them medication to sedate them. But even though they're not moving, their brains may be firing like crazy.
Yeah, that's right.
So when something happens like that, is that typical of someone with epilepsy? Are these status epilepticus patients, a number of them have epilepsy, or is there usually something else going on that's triggering this?
The times I've seen status epilepticus, it's most of the time these are people with epilepsy who, for whatever reason, have a flurry of breakthrough seizures despite sometimes patient may have run out of medication or they have some other infection concurrently that's making it their seizures to come out more frequently. So it is most of the time these are patients already with epilepsy. But you can have status epilepticus in patients who with a new diagnosis, let's say someone has meningitis, they have a brain infection, that can be disrupting the electrical activity and causing someone to go into status epilepticus. So there can be an acquired condition very acutely that can be causing, so if someone has a massive brain hemorrhage and the hemorrhage is causing the seizures. So yeah, it's more likely someone already has epilepsy that they're going to have status epilepticus, but you can have these off cases where some new acute brain injury develops.
And we talk about infectious cause of seizures and things, and you mentioned meningitis, and it's important because from a public health standpoint, we have situations where people are questioning the legitimacy of vaccination, and hepatitis, meningococcus, meningisemia, all those, a lot of that can be prevented with vaccination. So now we have a situation where you don't see it in pediatrics because you don't work with the population, but a pediatric neurologist will see a patient in the hospital with seizures due to meningitis that potentially could have been prevented with vaccination. Let's say meningitis clears from the patient when they're in childhood. Does the seizures continue in those patients into adulthood? Do you see somebody who is, okay, the meningitis is gone now, but they had a seizure while having the condition. Do you see that continue into adulthood? Or now are they at more risk for epilepsy compared to somebody else?
It really depends on the case, and I've seen both. I've seen it where it's isolated to the acute illness. Then once the meningitis heals, then the seizures don't come back. But if someone has a more devastating case where it's encephalitis, where you get actual inflammation of the brain tissue. Meningitis is just when the dura, the outer membrane of the brain is inflamed. If you actually have changes in the brain itself where you get encephalitis, those are people who often do have seizures long term, even after the acute illness is resolved.
And is this something that can be managed? And is this something that can be managed on one med, two meds? Like, how often do you see people on multiple medications for something like this?
One medication is usually sufficient, but then you get into these uncommon cases where you maximize the dosage of the one medicine and people are still having breakthrough seizures, so then you escalate more medication. Now, typically, once you hit your third seizure medicine, then these are patients that are just by definition have refractory or very difficult to control epilepsy. So most of the time, one seizure medicine can control things, but some people require two or three. And once you're at the level of three, then there's other methods that are more than just medications that may be entertained. There are more invasive type methods like vagal nerve stimulation or even certain types of surgeries like epilepsy surgeries.
What about, so back in the day, electric shock treatments were a thing for very much like psychiatric illnesses. Is that for neurology as well, for seizures and whatnot?
I don't see it happening. It might, but not really in the practices that I've been working with, the epileptologists that I work with. I don't think it's happening anymore. Yeah, it is more for psychiatric conditions. And there can be overlap between epilepsy and underlying psychiatric disease. So
yeah, one of the newest terms I've heard is non-epileptiform seizures. I think that's a term called. It used to be called pseudo seizures, but that had a very negative connotation to it. And that's for people who don't have the generalized, when we think seizure, right, we think of shaking. The whole body stiffens up, they shake, the lips can turn blue, all things like that. But then you have patients who come in and maybe their arm is just, doing one of these. That's a focal seizure. You have patients who will call them just stiffen up, but not shake. They'll just be staring into the distance. And that's actually a very common pediatric seizure called absence seizures that's diagnosed oftentimes.
Yeah, so seizures have many different ways they present depending on whether the entire brain's involved or a portion of the brain's involved. And not all seizures look the same to a bystander seeing it happen. You brought upon the topic of non-epileptic seizures, which the outmoded name was pseudo seizures, but it's PC term is non-epileptic seizures, and it can be very challenging because I just saw a patient this past week. She has epilepsy as well as non-epileptic seizures.
Interesting.
And these are cases that are difficult to manage because when you do the EEG monitoring, you can see that there's a region of the brain that has irregular or epileptiform discharges. But then, so that patient actually is on anti-epileptic medication, anti-seizure medicines, but she does have as well non-epileptic seizures. When the EEG is running, she's doing the convulsive type movements, but there's no changes in the brain waves.
Interesting.
So these are people that, and they're not that common, but they can be a clinical challenge because you don't want to treat too strongly. You might think that the patient is in what's called status epilepticus. You mentioned
Mm-hmm.
status epilepticus earlier, when you have seizures that are not stopping despite medications, and that can be it could be fatal if not treated. So on the one hand, you don't want the patient to be in status epilepticus, but then on the other hand, if they're non-epileptic seizures, their brain waves are actually firing normally, and what you might end up doing is over treating them, and they can become overly sedated. They might need to be intubated, and that can become a challenge as well.
Yeah, I talk to the residents a lot about, the usefulness of diagnostic testing, but also from emergency medicine perspective, procedures. Every procedure carries with it a risk, and you don't want to do a procedure on a patient that can carry risk if you don't need to. So oftentimes we talk about intubation, putting somebody on a ventilator being a big one. And let's say somebody with really bad asthma comes in, they can't breathe, they have a hard time breathing. The last thing you want to do is put them on a ventilator, if possible, because of something called air trapping. They can pop their lungs, right? The same thing for people who have seizure disorders. If you have to put somebody on a ventilator because you're increasing the amount of medication you're giving them, it is what it is. But intubation by itself carries a lot of other issues too. You can have vocal cord damage. You can also cause what we call barotrauma, or lung injury, and you can also just have somebody just drop their blood pressure with the medication you're giving. So it is that fine line of treating what you're seeing, but also trying to balance between, is what I'm seeing a true seizure? Can this be managed in other means, and not? And it's difficult, especially in my perspective, where you have to make a quick decision. What do I do? Do I take this person's airway? Do I, dial back the medication? And a lot of it has to come with knowing the patient's history too.
So there are, from my clinical experience, there aren't that many patients who have, like, on the grand scheme of things, who have non-epileptic seizures, and the ones who do, they often come to the hospital frequently. I know the ones that do roll in frequently. If someone in the ER reaches out to me and identify that this is someone who has non-epileptic seizures, we can try to avoid any unnecessary, potentially harmful procedures if we can avoid it. But that's right. Yeah, the history is always very helpful. If there's no one at the bedside, if the patient's unrecognizable, then you're left with guessing.
Yeah. And of course, the other thing is these medications that we're giving are not benign by themselves too. Keppra, so correct me, Keppra is a sodium channel blocker. Is that correct?
Yes.
That's like, I feel, first line for many patients. Even the ER, if I don't know what's going on, I'll just give them Keppra, but that can cause low blood pressure, it can cause hypotension. So I run the risk of, if I give them too much, now their blood pressure drops, and I have a patient with low blood pressure who can't perfuse their brain. That's another issue altogether.
Every anti-seizure medicine has its own set of side effects. Keppra tends to be the most well-tolerated of the rapidly infused anti-epileptics, but Dilantin is one that can really drop your blood pressure and your heart rate. But anything that you're giving to a person could potentially have adverse effects. If some people have allergies, some people have side effects.
And I want to actually talk about something, switch gears a little bit about overall seizure picture, because one thing I tell EMS and the residents and students and all that is, not all shaking is seizure. I always say the patient exhibited seizure-like activity without knowing their history. Patients are coming in, I don't know them, they have no history that we know of, but bystanders called 911 because, they were having a seizure. And I feel like that comes out to be 50% true. The patients exhibit shaking that people think, he's having a seizure. But the reality is, they could have just passed out, and you can't have shaking when you pass out.
There's a condition it's technically called convulsive syncope. So a person loses consciousness, and then right after losing consciousness, there can be jerking movements. Like, typically it's myoclonic jerking movements of the arms and legs. And it's not a seizure. It's just it's an immediate reaction to passing out. And that can happen in in a healthy person, and it's not a seizure, but it can look very much like a seizure. I remember most neurologists probably were exposed to this at some point in medical school. There's this really grainy video from must be the 90s or 80s, from Germany. There's these medical students that voluntarily submitted themselves to syncope, like they were like,
Jesus,
like hyperventilating, and they were on like a gym mat, and there was a line of medical students, and each one would hyperventilate to the point where they syncopize, and then they would just fall on the floor, and you'd watch them, and about half of them, after kind of like being lowered to the floor, their body would start convulsing for maybe 10 to 20 seconds. And not everyone. Some of them just kind of fell lower to the ground and did nothing. But that was to demonstrate that the mere act of passing out can involve jerking movements of the limbs that look like seizure, and they're not.
It's interesting because I feel like nowadays that would be like a TikTok challenge. You know, make yourself pass out and then let's see if you shake or not. Now, I'm not saying do that. Please, for the love of all that is holy, make this not be a TikTok challenge. But I can just see, you know, like next generation doing something like that. So there was actually a very good video of Hank Gathers, who unfortunately was an athlete. He was in college. He was a basketball player in college, but he unfortunately died on the court of a game from an arrhythmia. He had what we now know hypertrophic cardiomyopathy, or basically an enlarged heart. And his story was one of the reasons for now putting AEDs into schools and, you know, gyms and everywhere else.
Yeah.
But if you look at the video, and I tell this to my EMS crew, that it looks like he falls to the ground and he has shaking. He almost like he looks like he has a seizure. And I asked my EMS crew, what do you think that call went out as? And a lot of them will say seizure. You know, oh, he had a seizure because he actually woke up. He got up and then he you know, passed out again. But he's basically going to cardiac arrest. But cardiac arrest can also look like a seizure.
That's right. That's right.
How is there a good clinical way to differentiate between the two? Like, how do I know somebody's having an actual seizure versus going to cardiac without obviously a cardiac monitor, with just, you know, walking along the streets per se?
There are certain clues. Now, not everything is foolproof, but if someone has what's called a generalized tonic-clonic seizure, so when you have stiffening followed by jerking, convulsion with loss of consciousness, more often than not, patients will clench down, their teeth will clench down on the side of their tongue, and very frequently you'll have this tongue laceration on the sides of the tongue, not the tip. And that's a unique feature of a generalized tonic-clonic seizure. So if that is noted, when you examine the patient, that can be a sign of that this was a seizure and not some other form of syncope. If also the phase after a seizure is what's called the post-ictal phase, when the brain is overly exhausted, because during a seizure you get this increased metabolism of the brain and it depletes a lot of energy. So afterwards people are typically very tired, drowsy, sometimes completely snoring and not rousable. If that phase is present, it's very likely it was a seizure. If there is no phase of drowsiness, lethargy, and the patient is pretty much back to themselves right away, it makes it less likely it's a seizure. Now, there's caveats with that because there can be partial.
There's always exceptions, yeah.
But if you see that the tongue bites on the sides of the tongue, that's a key feature. If there's a prolonged post-ictal phase, also if someone urinates on themselves, that could be a sign of a seizure. That doesn't always happen, and it can happen in other settings too. But those are some of the, and we're often left with the same question that you posed, that we don't always know. If there was no witness, that's even harder. Most of the time we'll do a preliminary workup in the hospital with an EEG to see if there's any irregular brainwave activity. Now, the EEG is a test that can be, in patients with epilepsy, you can often have a normal EEG. So just having a normal test doesn't exclude the diagnosis. If you have an abnormal test, then you can rule in the diagnosis rather easily. So it's, what is it, specific but not sensitive?
Yeah, I was just going to say, it sounds like that old stats line. It's not sensitive, it's very specific, but that is the main one. Now, and is that the quote unquote gold standard? You know, that's the thing that, you know, if you have an EEG that's positive, that's a gold standard. We're done. If it's not, now let's say, obviously you don't do the outpatient world or not, but you know, patient comes into the ER. I do a cardiac workup thinking, well, it sounds more seizure-like, but you don't have a history. Let me do a cardiac workup too. That comes back fine. Yeah. And I start thinking, this sounds like a seizure. Now what? What do I tell the patient? Because I'm not admitting every seizure patient to the hospital. Well, hopefully. Yeah. But what do I now tell the patient? Like, hey, you probably have a seizure disorder. Should you drive? You know, like, what am I do? What do I?
Yeah. Well, in addition to the EEG, we do imaging of the brain. A CAT scan of the brain is pretty much the standard, and sometimes we'll do MRI as well. So yeah, once you've gotten, a person has had a seizure, and let's say it's the first one. If it's the first seizure and you don't identify anything wrong on the brain, like you don't see any scar tissue in the brain, you don't see any blood in the brain, you don't see an old stroke. If the imaging looks normal and the EEG looks normal, then you're at a crossroads. What typically I do is I don't treat after a first time seizure with seizure medications, because this could just be a fluke one-off event that might never happen again. And then if you start anti-epileptic medications on the patient, then you're basically telling them they have epilepsy, and there is restrictions with driving, restrictions with sort of heavy machinery type work, and you don't know, this might not happen again. So that's one scenario. First time seizure, you don't have any concrete abnormalities on any of the imaging. If, however, it's recurrent, let's say they had a seizure a month ago and they come in with another seizure, or at least 2 seizures, more likely 3 or more, but yeah, I guess by definition, you have at least 2 seizures. At that point, I would then treat, even if the imaging is normal. It is pretty commonly normal in a lot of patients with epilepsy. And at that point, you can start one of your common anti-epileptics like Keppra. You would want to have them referred to a neurologist. They may want to do longer EEG monitoring. In the hospital, we often do these routine EEGs that are about 30 minutes to 1 hour of recording. But if you do a longer monitoring, which is over days, you have a higher likelihood of catching a seizure or just an irregular brainwave that could tip you in the direction of epilepsy.
Would you submit a patient in the hospital to something that would trigger the seizure? Like, would you show them flashing lights or something to that effect to try and, while they're having the EEG?
Yeah, so there's different things that we do. One of them is, it's funny you mentioned earlier, the flashing lights. It's photic stimulation. That's one thing that we can subject our patients to. And the other is sleep deprivation, so keep them up late. So there are certain certain states that can make a seizure more likely to happen. So yeah, if you're sleep deprived, if you're stressed the brain with lights, it's not, the other thing that can be done, which isn't done as frequently anymore, but you can hyperventilate someone, and that's not usually done too frequently anymore.
Only in Germany in the 1980s, apparently, for experiment purposes. And one thing that people need to be aware of, too, if they're on seizure medication, is alcohol use. Other medications can, what we call, lower the seizure threshold, meaning if you have a history of seizures and you're on a medication, that can make you more predisposed to having a seizure because it can affect, the neurochemical process in the brain. But alcohol is also one of those drugs that does it. In fact, we often see our chronic alcoholics come in with a seizure, and for the ER, it's this person having an alcohol withdrawal seizure, or they're having an epileptic seizure just because either they're not taking their seizure medication, or they're taking the medication, but they decided to go and binge drink for a weekend too.
Yep, that's a challenge we see all the time. So alcohol, when in withdrawal, affects the GABA receptors in the brain, and that can cause seizures. And then I didn't get into some of the nitty gritty of like what is epilepsy and what is just a seizure. So you can distinguish epilepsy from just a seizure without epilepsy as to whether or not it's provoked. So a provoked seizure is something that's outside the brain that induces a seizure. So alcohol is a provoking agent. So if someone drinks heavily and they goes into withdrawal, that would by definition be provoked seizures and not truly epilepsy. Now, oftentimes I've seen this in patients with alcohol withdrawal. A lot of times patients with alcohol use get head injuries, and you can. So I've seen people with both epilepsy and alcohol withdrawal seizures in the same patient. So these are people who would be on long-term seizure medications, so they have epilepsy, but they're also drinking, which is lowering their threshold for seizure in addition. So it's like,
and they fall, they hit their head, and they can get severe concussions enough, or severe enough head injuries that now they have a TBI, or basically a total brain injury, which also makes them more predisposed to having seizures too. We see a lot of that, I think, in veterans and things, sports players, professional players who get hit in the head a lot, football players being one as well. It's tough because there's also, like I said before, a bit of a stigma attached to seizures. The idea that if you have a seizure, you're disabled, and that's very much true. There's things you cannot do, and you mentioned already, you can't drive, you should not be operating heavy machinery. So now you have a whole lifestyle adjustment and a lifestyle impact by one diagnosis, and it's not a diagnosis to make lightly too.
So with driving, it's not a permanent removal of your driver's license. So every state has different laws. In New Jersey, it's 6 months. So if you are diagnosed with epilepsy, meaning you have a predisposition to seizures requiring medicine to treat, you can still have a modified driver's license as long as you don't drive within the 6 months of your last seizure. Without any seizures for 6 months, you can go back to driving. That's just the threshold. That different states have different thresholds. I think Maryland might be 3 months, but New Jersey, Pennsylvania is 6 months. I think New York was maybe 1 year, but things may have changed since I last worked in New York. So it's not a complete I can never drive again scenario. It's once things are under control, then you can go back to driving, but we don't want to rush you into it because having a seizure while driving can be fatal.
Yeah. And I think that's something that people need to be aware of too. It's not that, okay, now I have epilepsy, my life is ruined here. It's no. You need to be very cognizant of what you put into your body, what you expose your body to, but also obviously, take the medications as prescribed to you and adhere to that regimen, because otherwise any deviation, it's going to be a problem.
Yeah. So with controlling seizures, there can be sort of lifestyle modifications that can help, but ultimately if seizures are occurring without medication, then basically adherence to that medication is of the utmost importance. And in addition to that, trying to get regular, improve sleep habits, improve dietary intake, lowering stress levels, these are all things that can make it better in the long term to prevent seizures, in addition to the medicine that's being prescribed.
And you talk about a lot of that, sleep habits, diet, and all that, lifestyle. These are issues that keep coming up among all the guests that I've had on here, pediatrics, internal medicine, now neurology. We hear a lot recently in the news about, making America healthy again. And there's an underlying element that is true, which is there's a lot in that we do in our daily lives that is unhealthy. Food choices, activity choices that predispose you to many other conditions. And if you have chronic illness, even more so. And I think that needs to be addressed so much more, and just not in a primary care level, but also in a hospital setting, in the ER, in the inpatient wards, where you have to really hammer down the education. The medication is going to help control this, but it won't stop everything. We need to have a discussion of what your daily routine is like, what you're eating. And I wish there was more resources that we can give patients, especially in the hospital, to kind of push them towards that, but there isn't. It's frustrating.
I know, I agree. And it's not only with epilepsy, it's also, since my fellowships in vascular neurology and stroke, it's the same thing. There's many lifestyle modifications that can prevent that stroke from happening, so that they don't even need to see me in the hospital. But it is a combination of things. There's, especially for epilepsy, lifestyle changes alone won't fix the irregular electrical pattern in your brain. So the medicine's really the only thing that can prevent that seizure, but there's things that can, in addition, can help improve your chances of not having further seizures.
Yeah. And it's all important too for people to understand that people who have seizures, it's not their fault. It's not something they did or didn't do. Developmentally, you could be a healthy developing person, and here we are. There is a correlation, and I talked about it in another episode about febrile seizures, where if a child has complex febrile seizures from an illness, and we touched on some of those, hepatitis, meningitis, whatever, they do increase the risk of epilepsy and seizure disorder into adulthood, but it's only about 3 to 5%. It's not a guarantee. But beyond that, you just don't know. Your brain could be hardwired differently, and that's not your fault. It's not the fault of the parents or anybody else. So
there should not be any type of stigma towards epilepsy. This is out of the realm of control. This is just something that some people are born with. Some people may have developed it later in life, and it's just the way things are. And it should not be looked upon as a disability. People with epilepsy can live fulfilling, normal lives. It's just there's an additional component that just has to be taken care of.
And you mentioned about stroke and vascular and all that. I do want to get you back on here. There's a lot to talk about with stroke. So much information, misinformation. Capitol Health is having a stroke conference this coming September. I believe it's September 23rd. So, if you want to check the hospital's website, Capitol Health, in New Jersey, if you're in the area, and you're a healthcare provider, please, by all means, check it out, register, because I'm going to be one of its speakers.
Oh, wonderful. What are you talking about? What's the topic?
Oh, I'm going to be talking about everybody's favorite clot buster, TNK.
Wonderful.
I'm trying to rope in some of my colleagues to have like a panel in a way to have a conversation about this, pros and cons and all that. So far, nobody's biting. I think everybody's too scared. So I might have to bribe some people. But, so I think maybe in September, have you back on, talk about stroke a little bit more, tie that in. Is September Stroke Awareness Month? Is that what's going on? There's everything has an awareness month anymore.
I
thought
it was May.
Okay.
Maybe every month is some type of awareness. So I thought May was Stroke Awareness Month, but
okay,
maybe they're trying to add a second month to the year.
Yeah, maybe try to get everybody's CMEs in with this thing. So,
but there's one other thing I want to mention. Just tying stroke to epilepsy. The most common cause of seizures in adults is actually a previous stroke. So strokes cause scar tissue to develop in the brain, and typically not on the same hospital admission. It's usually months afterwards. So someone has a stroke, they recover from the stroke, and then months later, out of nowhere, the patient has a seizure. And that is a very common scenario that I encounter. But this is typically more later adulthood that I'm seeing. I believe it is statistically the highest cause of epilepsy in adults.
Are you starting patients on seizure medication if they've had a stroke then?
Yes, because that scar tissue is not going away. That will always be there. That scar tissue that's developed disrupts the normal electrical activity, and therefore, even if it's a first-time event, even if I don't catch anything abnormal on the EEG, I'm very much inclined to treat, just knowing that there's been a disruption of the normal brain phase.
So somebody who comes into the ER, basically they've had a stroke, we admit them for the stroke, they go home, they're in whatever functional state they are. You're not necessarily starting them on seizure medication at that point.
That's correct.
But if they come into the ER 6 months later and I see, I had a stroke, I was here 6 months ago, now I've had a seizure, we're done. I'm starting on seizure medication.
It's not, if the stroke was large enough in the cortex, it depends really what region of the brain, but there's frontal lobes, parietal lobes, occipital lobes. These are regions of the brain that can lead to seizures. And if the stroke was large enough, I would very likely just treat for epilepsy at that point.
Okay. SANS imaging, SANS EEG, are we still getting all
we
that?
Or are we still get it. Okay. Just also, sometimes you don't know sometimes if they're having subclinical seizures that are not necessarily being identified. So you would want to get the EEG as well, just to make sure things are under control. So we would do all the workup, but my likelihood of keeping that patient on the seizure medicine is very high.
That's good to know for EM in general as well, in patient practices. Well, Dan, thanks so much.
Yeah.
Thanks so much for coming on.
Thank you for having me.
That was a good talk. Like I said, we'll get you back on here, talk about stroke at some point, maybe not May of next year.
Yeah.
During Stroke Awareness Month, but obviously, hopefully in the near future.
Yeah, no, I'd be willing to talk about other topics. That sounds fun.
All right. Well, Dr. Dan Landau, thank you so much for coming on. Take care, and we'll see you next time.
All right. Thank you. Take care.
All right, that wraps up another episode of the JAFERD Cast. Thanks again to Dr. Dan Landau for joining me. We talked about seizure, we talked about risk factors, treatments, conditions, and we also discussed the stigma behind it, which is it really shouldn't be a stigma. Obviously, a lot of choices of your own health are tied into food, sleep habits, normal healthy lifestyle, but seizure epilepsy in general can be something that is acquired later in life from infection or something you just unfortunately happen to have. So please, if you have something like this, as always, I encourage you to speak to your regular doctor and find treatment choices that are right for you, especially if you have questions about your own health. I always encourage constructive thoughts, comments, and suggestions about this show. You can leave them in the comments section for those on YouTube, or email them to me at jaferdcast@gmail.com. If you're in the healthcare field and interested in being on the show to discuss topics in healthcare, or if you have a passing interest in healthcare topics as well, please feel free to reach out. It's like with anything, though, please don't take my word for it. Do your own research, talk to your own doctor, because at the end of the day, like everybody else at work reminds me, I'm just another fucking ER doctor. Make a choice, everybody. We'll see you next time.